Okay, so this is part two of the week 2 lecture, 2021 for upper extremity. We're now getting into this cluster of shoulder problems that really can kind of be in kind of one umbrella. They're all kind of very similar in similar ways, and they all have similar causes in similar ways, and they all have similar treatments in similar ways. If you can get your mind to kind of cluster all these different shoulder issues together, it'll get so much easier in terms of figuring out what to do and what to do in terms of treatment. They're all called shoulder impingement or shoulder impingement syndrome, and they're all an issue of space and flow, and they're all revolve around the rotator cuff. We talked about the rotator cuff in the anatomy lecture, how those muscles work kind of with each other to find balance, to maintain the space and flow if you do tasks that involve rotational movements, especially overhead movements. The infraspinatus, teres minor, subscapularis, supraspinatus, they all kind of pull back and forth, and they have that perfect little balance to them. And this balance is thrown off very, very easily. That's when you get compromised biomechanics, compromised space and flow, pain, issues with the shoulders. Generally speaking, rounded shoulders, protracted scapula, tight subscapularis, tight pectoralis minor, that rounded shoulder kind of thing. So you're tight in the front of your body, tight in your neck, leads to this impingement, compromises the space. Again, think of that exercise where we slouched, could not lift our arms up. It crunched up the space. There was no space for that humeral head to glide fully up and down and all around. Causes this problem. So then you're just jamming up against it. Every time you try to move, any kind of rotational movement you try to do, it irritates. Irritates the tendons, irritates the muscles, causes swelling, inflammation, compromises the flow of blood in and out. This whole cycle of impingement, space and flow compromise happens in large part because of postural, lifelong kind of issues, or just a lot of repetitive overhead kind of motions. So you get the irritation, inflammation, and then the rotator cuff muscles start to tear, or they get weak. And then what happens then? One is torn, one is weak, the balance is thrown off. The space is thrown off. It can't maintain that space as it's going in all these different directions. So irritation, swelling, it's just a cyclical kind of thing. Also causes bicep tendinitis, as we'll see. Also causes this rubbing, pushing in there that causes bursitis, the swelling of the bursa. Also causes something called bone spurs, which is this grinding of bone on bone, this pushing and irritation, causes these little bony growths in the shoulder. When surgeons go in, and I saw this as students, pretty cool, when they go in and they clean out the shoulder, and they may repair the rotator cuff, they usually clean out bone spurs as well. Usually they kind of acclimate, especially with older folks, or it's so common that they have these kind of rotator cuff issues. So that's kind of it in a nutshell. We'll kind of break it down more. Shoulder impingement syndrome. Here you can see how when the space is compromised, it's pushing up into the bursa. That's going to cause bursitis. Pushing up into that supraspinatus tendon. That's the one that really abducts your shoulder. That's the most commonly torn muscle when somebody has a rotator cuff issue, whether it's irritated or it's actually torn to the point where they need surgery. 9 times out of 10, it's the supraspinatus, and 9 times out of 10 is because of this pushing, this lack of space kind of thing. Here's the space again. See how it pushes up into the bursa. The humeral head is pushing in there, causing irritation, rotator cuff tendon pain, compromise, tearing, fraying, all these awful issues. Cause of shoulder pain impingement. Generally what happens as the rotator cuff gets weak and the poor posture and other issues, the humeral head, that's like a fist coming into your cupped hand, which is the acromion. The humeral head into the acromion, the glenoid fossa, which is where the little cup, the joint goes in of the shoulder. What happens is it starts to move superiorly, so it starts to move straight up into the fossa, compromising the space, and also starts to move forward. So it's coming up and forward. And this pain, this loss of motion, is generally caused by the head coming up and forward, superior, anterior migration, reducing space and flow. Influenced by poor posture, influenced by weakened, torn rotator cuff muscles. And we'll do this in the lab, and you'll see there's this great exercise you can do, this great joint mobilization, where you just push the humeral head back into place. In a lot of cases, your patient will say, oh, that feels so much better. And they'll get more motion, less pain. You're just pushing it back where it should be, because those compromised muscles and the posture stuff has pulled it forward and up more than it needs to be. So to fight this, think about it. The problem is it's coming forward and it's coming up too much. To fight this, you do the opposite, pushing it back and pushing it down. So we need to do manual therapies, exercises that push it back and down. Inferior, posterior migration. Inferior migration opens up the space. Anterior deltoid primarily pushes the humeral head upward. The rotator cuff muscles push the humeral head downward. So we can keep those rotator cuff muscles healthy and strong. They're going to push it downward where we want it. Another great exercise, this has been shown through research pretty coolly, resisted shoulder extension. This also pushes the humeral head downward. So when you're thinking about any of these injuries to the rotator cuff that we're going to get into, any kind of impingement, rotator cuff irritation, bursitis, bicep tendinitis, think of shoulder extension because it pushes it down. We want to go push it down, that humeral head. We don't want to let it go up and smash into there. Scapular depression, we don't want that protracted. We want it back. The serratus, lower traps do that. That's a really good exercise. Pushing into a chair or something. Humeral head, scapular depression is another really good thing. External rotation is a really good thing. It opens up the space. Scapular depression, we said that. Shoulder extension. Those are three big exercises that help with all of these shoulder issues. It's the same for all of them. External rotation, scapular depression, resisted shoulder extension. Any kind of exercise or modality or stretch that do one of these three things is a really, really good thing for the shoulder. Posterior migration, just pushing it back. The pec major and minor push it forward. The external rotators, when I say the external rotators, I mean infraspinatus, teres minor, and the rhomboids push it back. They're the good guys. We want to strengthen those suckers. They are the key to a healthy shoulder. So to fight anterior migration, strengthen external rotators and the rhomboids and the shoulder extensors again. Rotator cuff tear and irritation. The rotator cuff is just not built to last. Over 90% of people over the age of 80 have some degree of tear. It just wears out and gives out. It's just too flexible for its own good. It goes in too many planes for its own good, and it just wears out and it goes. In a lot of cases, it's just a subtle thing. They can be just lifting a book. Like, oh my God, I blew out my shoulder by just lifting this little book. No, it was like the straw that broke the camel's back. It irritates, it swells, it frays, and then boom, that last tear that happens when you're older, kind of my age and up, late 50s, 60s, 70s, and 80s. Very, very common. Keep this in mind. You have your little old ladies and men in the nursing home. You're doing rehab with them, and you're like, oh, that shoulder is pretty tight. I want to start stretching that and working on it. They aren't 25. You start going too fast, too quick, you're going to rip it even more and really set them into all kinds of pain that you just don't want to do. So the rotator cuff rotates in and out and helps keeps the space, that flow, that inferior migration, pushing it down, which we want. This is a good video, but those of you just listening, definitely check out these videos. It shows you the surgery. This is the classic fraying and tearing. Frays and frays. There's a tear. That's a subscap, looks like. This is the supraspinatus. This is the one that really gets used and abused, and it's frayed and it's torn. It's really ripped apart. This is not good. This is usually very painful. Sometimes it's not painful. They just kind of gradually got used to it. And what they do is they go in and they sew it. Like they'll sew this part to this part. Classical, they'll go in, they'll sew this, and they'll go into the humeral glenoid fossa, clean out all the bone spurs, sew it up, fix it right up. Here's the degrees of tears. Partial tears, which are common. versus a full tear. Full tear is a lot of times it's trauma. You know, they've had a sports or car accident kind of thing. Again, trying to simplify it. There's good guys and bad guys in the shoulder. We want to stretch the bad guys, and we want to strengthen the good guys. The good guys will pull it right back into the place that we want. And if we can stretch out and calm those bad guys down, they're going to feel a lot better. The good guys, they're external rotators. Teres minor, inferior, the scapular retractors, rhomboids, trapeus, scapula depressors, serratus anterior, the lats. Strong good guys means good space and flow, good posture. Bad guys, we don't want tight. Bad guys, they really pull it forward, pull it up, jam it up in there, do all kinds of bad things. Subscapularis is a big culprit with this, especially with forward posture. You see a lot of that. Needs to be calmed down, stretched right out, straightened right out. Pec minor, we talked about that. Again, with this, that pec minor is a key muscle for all these impingement, rotator cuff issues. We're going to stretch that sucker out, the pec major, anterior deltoid somewhat. Try to get that anterior superior migration back and down again. Get that, restore the space and flow. The treatment box, we'll check this out in a second. So you're testing your big tests for rotator cuff. The three big ones we're going to do, the empty full can test. These, again, they call them tests and they're helpful when you're kind of learning this stuff. But I think eventually I want to get away from the tests. I know manual muscle testing. I know anatomy. I know what I need to do to potentially irritate a muscle that's compromised. Empty full can test goes after the supraspinatus. Will tell you whether that's sore or weak. Infraspinatus test will test the infraspinatus, which is just manual muscle testing of the infraspinatus. Curva lift-off test will test out the subscapularis. Hawkins-Kennedy, it's not one you're going to need to know for the practicum, but it's a good one. It's highly effective. And it'll tell you if there's distal impingement. It won't tell you which muscle is involved, and you need to know that because that's the muscle you're going to go after. But it will tell you, okay, there's definitely some serious impingement going on here. How are you treating it? Modalities, stretching, strengthening, that sort of thing. Okay, let's get into that. Into that treatment box for the rotator cuff. All kinds of stuff here with this. All right, this is good news. This is white, so you don't need to know this for the midterm exam. You do need to know this for practice in real life. So it's here as a reference. That's shoulder bursitis. I've had good luck treating that. It's usually not that difficult to get rid of. Subacromial impingement. This is kind of a general term. Impingement, we're calling it a general term, but we really need to kind of drill it down to which muscle is involved. Hawkins-Kennedy is a good test for that. The near test, which is for the near test as well. Hawkins-Kennedy painful arc test. Checking posture, checking pec minor. And you'll see there's similarities with all these because they're all very similar in terms of how you assess and treat. Really the only difference is which muscle's involved. You can figure out which muscle's involved. They're all the same. You think, oh my God, I have to memorize all this stuff. Just memorize it once and think, I got to figure out which muscle it is, and you really got it. Modifying activity, overhead stuff, reaching back stuff, as you would think, is a problem. Don't want to really activate that anterior deltoid and those pecs. You want to calm those suckers down. Try to avoid things that really get those things down, like pushing open a heavy door, picking up heavy objects. Again, sleeping with your shoulders slightly adducted. Modalities, manual therapies, some cool exercises that we kind of talked about. We'll get into all these in the lab. This is a cool one. There were a lawnmower. We ever talked about that core stuff. And then you're kind of progressing it, getting into these Houston exercises, which are cool exercises to kind of know about. We'll do those, kind of get exposed to those. Don't need to be an expert or anything like that. There's pictures down below showing those Houston exercises. Partial tear, non-surgery, pretty much the same. All that's different is you're trying to tease out, is it really the subscap? Is it the supraspinatus? Which muscle is it? Empty full can will be the supra, carpal for the subscap, infraspinatus test for the infraspinatus. So you need all three of these tests so you can kind of tease out which muscle it is. And then you're pretty much treating it the same as the other ones. Surgery, There's some cool stuff here on taking care of a sling, shower care post-surgery. These are great OT kinds of things. How to remove take your shirt off post-surgery, and then the protocols. We have all these protocols. This is the surgery protocol. This is a kind of a common one. Really, you have to go to your particular surgeon. They have all the little nuances, how they want to do it. But here's one to kind of give you an idea of it. You're kind of lost in a clinic or something. This is, again, a resource you'll have in your Google Sites, not something you need to know for the midterm exam in this class. Bicep tendinitis, the speeds test, palpate, the insertion of the long head. We'll do that in the lab. That really tells you what a bicep tendinitis is. That's, again, a space and flow issue. It's getting pinched in there. Speeds test will tell you if it's really the bicep tendinitis. And you're treating it the same, except for your manual therapies, modalities are going after this bicep tendinitis versus the other muscles. But everything else is pretty much the same. Down and dirty is a separate kind of thing. This is rotator cuff exercise progression. You see so many rotator cuff issues in the clinic, and usually they're non-surgical, what they call conservatives. They aren't going to go to surgery, or you have to at least try and see if you can do it and get it better before they resort to surgery, since it's so expensive. This is like a compilation of all the evidence. This is the latest and greatest stuff on how to rehab a rotator cuff. Gives you images. There's some great scapular depression, just pushing into the chair. Different levels as they progress, ideally some great wand exercises, pec minor stretches, doorway stretch, shoulder extension. That's the magical exercise for this. Resisted shoulder extension. All great stuff here. And here's the Houston, the different levels. We'll do those. Those aren't that hard to kind of do. All right, so that is the treatment box for rotator cuff stuff. Let's go back to here. Shoulder bursitis. I'm going to talk about how to treat it, but it's just the bursa getting inflamed, pinching, pushing up in there usually. I've had a lot of good luck with low frequency ultrasound, treating that. The ultrasound is great because it goes deep into the shoulder, low intensity, get that inflammation down. I've had a lot of good luck with that. Bicep tendinitis. What goes on with bicep tendinitis? This is the speeds test. So where is that long head? Right there. There's the long head right there. It goes through that bicipital groove. What is your first impression? At least I think all the stuff we're talking about. Here it goes right through that bicipital groove. What do you think? Tight space, right? It has to kind of glide through that groove, back and forth. When you palpate this on each other in the lab, you'll see that, oh, that's kind of sore in there. Why is it sore? It's pinching. Compromised space and flow, especially overhead stuff. Very commonly. And that's kind of where you do a lot of your treatment, right on the top of the anterior deltoid. And everything else is kind of the same. It's just restoring posture and biomechanics. Again, this kind of syndrome, this pattern, all these shoulder issues, lost space, irritation, imbalance, pain. She's really got a wicked knot there. It's kind of making her scream. But she's doing external rotation. The shoulder is in that closed pack position where it's most vulnerable, where it's the tightest. I got like a picture coming back, or quarterback, and she's screaming. Probably not her hair. But let's say it's her shoulder. That's a common shoulder spot. Internal rotation. A lot of times they'll say, oh, when I hook the seatbelt, it really kills. Because again, they're internally rotating, compromised position. Same with overhead. I had a mechanic once. I was in his 30s and his shoulders were just a mess. He did a lot of overhead stuff in the cold, hours at a time, and it just ruined his shoulders. This graphic may work for you. You may like, oh my God, what is this? Impingement. Rounded shoulders, protracted scapular overhead activity leads to impingement, tight pecs, impaired space and flow, and then you get all these different diagnoses. Here's some treatment that's just kind of simplified, kind of initial, and then later on, so you're just kind of calming it down, reducing gravity, aerobics, posture, and then you're kind of going against gravity more, or diagonal planes, increasing activity resistance. I'll kind of walk through this in the lab, I believe. Okay, so now we're back to our upper extremity dilemma here. We're going to figure out what to do with this person. I'll kind of give a demonstration of this in the lab, just kind of walk you through it. She's all these issues. She has thoracic outlet syndrome, and what's telling her that is that numbness and tingling more than anything. The test, and then you see her posture. So she comes in, she talks about numbness and tingling and weakness with overhead. You see her posture, you think, oh my goodness, she's probably got TOS. You give her that RUSE test. The RUSE test we'll do in lab. She's positive for that. You start palpating around those spots, those 3 thoracic outlet spots, the scalings, the pec minor. She's probably going to be sensitive, one of those 3 spots. That'll kind of tell you, okay, this is what it is. And then she has the forward head posture, the rounded shoulders. She reports right-sided shoulder pain when washing windows, overhead, dusting, overhead, that neck pain, chest. There's all those different signs. So with her, what you want to do is give her the RUSE test, number 1, assuming she's positive. Number 2, you want to palpate those areas. So that's, and that will kind of tell you, she's, with all her symptoms with these tests, probably TOS. How do we treat that? Kind of looking at our thing here, we're thinking the cause is TOS. I know that because she was positive RUSE, positive palpation in those key areas. How do we treat that? Posture. So doorway stretch, pec minor stretch, get her neck back, chin tucks, wall lineup kind of thing. Aerobic, get her moving. Manual therapy, I'm going to be going in there massaging the scalenes. Diaphragmatic breathing, it'll calm her scalenes down. So we'll be using her stomach muscles to breathe, not her scalenes to breathe. You could do modalities around these things. Stretches, the scalene stretch would be good. It's a nerve issue. It's a neural nerve issue. So you could treat it by doing nerve glides. Those are all good. And then your goals will go right back to her different functional problems, those pain levels, trying to reduce those pain levels, basically. This is for next week's test. This is the quick screening. There's the learning objectives. This is what is coming up. So that is